greet you in the precious name of my Lord and Savior Jesus Christ. Thanks for joining me in this video as we unpack edema. Alrighty, so first up, a little joke. Ever wondered why did C swell up? Well, because it was stung by a bee. Here's our clinical case for today, guys. A 47-year-old postmenopausal woman is seen for the onset of severe dyspnea over the last few weeks. So she reports no preceding chest pain, cough, sputum, or fever. Those are all important negatives. However, she does report our beloved leg swelling. Oh dear. Physical exam is notable for a blood pressure of 145/78 and a heart rate of 123 beats per minute. So she is tachycardic. Exophthalmos is present, as well as bilateral inspiratory crackles occupying approximately 1/3 of the lower chest with neck vein distension. She has a third heart sound, hello, with no murmur. Bilateral lower extremity edema is also present with warm extremities and a fine hand tremor. Those are important clues. Which of the following is most likely pathophysiological explanation for or of her heart failure? So is it A, anemia with a high output state, B, chronic symptomatic hypertension with resultant left ventricular hypertrophy and non-systolic heart failure, otherwise called heart failure with preserved ejection fraction? Is it C, hemochromatosis with subsequent restrictive cardiomyopathy? Is it D, MI with depressed left ventricular systolic function? Or is it E, thyrotoxicosis with high output state? I wonder. Let's break it down, guys. How can one really differentiate edema of cardiac, renal, and liver disease clinically? Well, I'm glad you asked. So if you're looking at cardiac issues, right, in congestive heart failure, edema is usually dependent, all right? It's mostly in the leg with engorged and pulsatile neck veins and an enlarged tender liver because of liver congestion. If the patient is obviously recumbent for a long time, they may have sacral edema, not necessarily peripheral edema in the leg, so watch out for that. Other features of cardiac disease are usually present, for example, a concomitant murmur of mitral stenosis or regurgitation, which could be a primary valve disorder or could be secondary to the underlying cardiomyopathy. Okay, renal etiologies, especially nephrotic syndrome. So here, edema usually starts from the face or periorbital and then descends and only later becomes generalized. And the urine, of course, will show massive proteinuria. In acute glomerulonephritis, the edema is also periorbital, associated with scanty, frothy, smoky urine. In liver disease, in cirrhosis of the liver, we know that there is ascites, and in advanced stages, there may be anasarca, there may be generalized edema, as well as other stigmata of chronic liver disease may be present. So what really is edema and what are the different types of edema? So edema is simply defined as excessive accumulation of fluid within the interstitial space. It may be pitting, it may be non-pitting, all right? So what are the causes of non-pitting edema? The usual culprits are mixed edema, right? And chronic lymphatic obstruction or lymphedema due to any other cause. Watch out for elephantiasis caused by the infamous Wuchereria bancrofti, which is a filarial parasite. Okay, guys, what are the causes of pitting edema? Well, the usual culprits are congestive cardiac failure, nephrotic syndrome, hypoproteinemia due to any cause, really. Watch out for protein losing enteropathy as a cause for hypoproteinemia. Deep vein thrombosis, which usually manifests as unilateral lower leg swelling, but it can be bilateral in some instances, can affect the upper limbs as well, right? Compression of large veins by tumor or lymph nodes, chronic venous insufficiency in the way of varicose veins. Listen, varicosely for that one. Drugs like calcium channel blockers, typically amlodipine, nifedipine, some non-steroidals can also cause edema, right? And of course, idiopathic, which is termed fluid retention syndrome, which happens especially among women. Okay, so what are the causes of periorbital edema or puffiness? So the number one culprit usually is nephrotic syndrome. You can also have acute glomerulonephritis, which causes this, or AKI. Mixed edema, Cushing syndrome, superior vena caval obstruction, angioneurotic edema in the setting of anaphylaxis or an allergic reaction, surgical emphysema, orbital cellulitis. It can be malignant exophthalmos, which speaks to Graves' disease, and dermatomyositis as well. Okay, so If you do have a patient with edema in clinical practice, how do you set about investigating such a patient? So investigations should be based off your history, physical exam, and what you suspect to be the underlying etiology. So in nephrotic syndrome, you do want to quantify your proteinuria. So you can do a spot urine protein to creatinine ratio, all right, and a value of above 0.05 is suggestive, or 24-hour urine collection for quantitative proteinuria, all right. Also, it's a good idea to do a liver function test, and you can quantify your total protein, and you can calculate your albumin to globulin ratio, and other investigations as per suspicion of the cause. Alrighty, so in nephrotic syndrome, the common culprits can be post-streptococcal glomerulonephritis, so it's good to do a anticephalizin O titer, right? You can do your complements to your C3 and C4 if those are low. That may speak to a flare of lupus nephritis. ANF, which is anti-nuclear factor, speaks to lupus nephritis. ANCA has anti-neutrophil cytoplasmic antibody, which speaks to your vasculitides. All right. And then, of course, your glycated hemoglobin and your fasting lipogram and hepatitis screen, all of these in terms of working out what is the primary etiology behind the nephrotic syndrome. Don't forget malignancy workup as well, if clinically suspected. If you're thinking about congestive cardiac failure as the cause of your edema, then it's prudent to do a chest X-ray. Look for the classic changes that accompany cardiac failure. We know it to be cardiomegaly, upper zone diversion, curly B lines, effusions, and so forth. Electrocardiogram, right, and echocardiography as well to look at that heart. If you're suspecting cirrhosis, it's a good idea to do your liver function test, including a total protein. You can quantify your albumin to globulin ratio, international normalized ratio, because cirrhosis gives you a coagulopathy, all right, on many reasons, right? Ultrasound abdomen, looking at that liver, and other investigations as per suspicion of the cause, so hepatitis screen, autoimmune serology, and so forth. Right, if obviously you think there's hyperproteinemia, I want to quantify it by doing your serum total protein and quantifying your albumin to globulin ratio and other investigations based off what you suspect to be the cause. If there's hypothyroidism, do your thyroid function test, and of course other investigations as per your suspicion. So everybody, back to our clinical case. So we had a 47-year-old female who's postmenopausal who comes in with essentially lower limb swelling, and she is tachycardic, but the blood pressure is borderline high, but she has features of hyperthyroidism. Okay, which is the most likely pathophysiologic explanation for heart failure? And the answer is thyrotoxicosis with a high output state. All right, so this patient presents with evidence of cardiac failure, and the history and the physical exam confirm this diagnosis. Now, what's a big clue, guys, that this is a high output state is because the extremities are warm. Physical exam also shows exophthalmos, alrighty, together with a fine tremor, and this is suggestive of hyperthyroidism. Remember that thyrotoxicosis, together with anemia, nutritional disorders, and systemic AV shunting can all cause high-output cardiac failure. There's a beautiful mnemonic for high-output cardiac failure. It's called a bad fat chap, and that you can find on my video concerning edema. Right? There's a mnemonic video I've made before. Have a look. Now, although systolic and diastolic dysfunction are more common causes of heart failure, disorders associated with a high output state are often reversible. And that is the key, everybody. High output causes of cardiac failure or causes of high output cardiac failure are reversible. So even though they are not that common, you got to be on the lookout for them because you can change the situation by addressing the high output cardiac failure. So always pursue a diagnosis of these whenever clinical clues are suggested. So this is a beautiful cartoon courtesy of MedComic.com. A big shout out to George Muniz and company, illustrating the differences between systolic and diastolic dysfunction, right? So in systolic dysfunction, there's impaired contractility versus diastolic dysfunction, where there's impaired filling and relaxation. And in systolic dysfunction, we have thin, weak heart muscle with a low ejection fraction, often have a S3 gallop. But in diastolic dysfunction, we have a normal ejection fraction. So this is called heart failure with preserved ejection fraction. We have PIF with S4 gallop. And of course, the etiologies as mentioned. So systolic dysfunction, you're thinking about ischemic heart disease, chronic hypertension, dilated cardiomyopathy, and our beloved myocarditis. But in diastolic dysfunction, it's hypertension is the main one. Aortic stenosis, don't forget. You have restrictive and hypertrophic cardiomyopathies, fibrosis, sarcoidosis, hemochromatosis, aging, constrictive pericarditis. Okay. I just want to encourage you about the greatest commandment given us by the Lord Jesus in the book of Matthew, chapter 22, verses 37 to 39. And this has to do with the most important quality that we should have, and that's love. So first up, he says, so this is in response to a question that one of the Pharisees posed to Jesus in terms of what is the greatest commandment. And Jesus replied by saying, love the Lord your God with all of your heart. All right? With all your heart, all your soul, and with all your mind. This is the first and greatest commandment. The second is just like it. Love your neighbor as yourself. So we are called to love God and love people. These are my references, everybody. God bless you. Thanks for joining me. I'll see you next time with another beautiful video in algorithms and mnemonics and internal medicine.